All right, going to do a short NCLEX style review. This is designed for your long-term NCLEX board taking endeavors. This will focus on a lot of the subjects. We did this module with the respiratory. We'll start off with COPD. Chronic lung disease includes bronchitis, pulmonary emphysema, and asthma, which categorized under chronic airflow limitations. Emphysema and chronic bronchitis, termed chronic obstructive pulmonary disease, COPD, characterized by bronchospasms, which is the narrowing of the airways, and dyspnea, which is like the shortness of breath, tachypnea, things of that nature. The damage to the lung is not reversible and increases in severity. So those are two main characteristics of emphysema, chronic bronchitis, termed as COPD, non-reversible and increases in severity. Asthma, unlike COPD, is intermittent with reversible airflow obstruction and categorized with wheezing. Tobacco smoke is the primary cause of COPD in the United States. Compensation occurs over time with clients with chronic lung disease, and ABGs are altered, which you all were looking at that for how to read these ABGs. As COPD worsens, the amount of O2 in the blood decreases, resulting in hypoxemia, and the amount of CO2 in the bloodstream increases, resulting in hypercapnia. Chronic respiratory acidosis, and your kidneys compensate by producing bicarb or retaining it. Not all clients with COPD are CO2 retainers. But we still have to be, only a very small percent are actually CO2 retainers, but we have to treat them all like they're CO2 retainers because it's such a serious situation where if we apply too much oxygen, their respiratory drive will be decreased. Even when hypoxemia is present, because CO2 diffuses easily more across lung membranes, blah, blah, blah. In advanced emphysema, due to alveoli being affected, hypercarbia is a problem rather than bronchitis, where the airways are affected. It's imperative that baseline data be obtained for this client. Make sure that you look through the chart and check what their baseline data is, so you can compare today's data or the data, the original data, with what's going on today. Nursing assessment, assess for changes in breathing patterns, such as an increased rate or increase of depth. Assess for overinflation of the lungs, which causes rib cage to be remain partially expanded. Barrel chest, that's achieved because the patient loses the elasticity in their lungs, lung tissue, and they use that accessory muscles in order to breathe. You'll assess for generalized cyanosis, so lips, mucous membranes, face, nail beds. You'll assess cough, whether it's dry, productive, present at all. You'll assess for to see if they have a higher than average CO2 or a low CO2. Use your pulse oximeter for that. Decreased breath sounds. They could have atelectasis, which is a decreased breath sound, usually in the lower parts of their lungs. Assess lung sounds such as coarse crackles, as they tend to disappear after coughing and wheezing and disappear. Dyspnea, orthopnea. Assess their nutritional status. Look at whether they've lost weight. Ask them about their activity intolerance in daily living. Assess their anxiety concerning breathing, as it could be manifest by anger or fear of being alone, or fear of not being able to catch a breath. Productive cough and comfort can be facilitated by the semi-Fowler or high Fowler position. Whenever you suspect a patient is having any kind of respiratory issue, usually one of the first things you want to do, even before you get their vital signs, put them in a semi-Fowler's or a high Fowler's position. That helps expand that respiratory system and makes it easier for them to breathe. Kind of your first intervention. It lessens pressure on the diaphragm and abdominal organs. Gastric distension becomes a problem in these clients because it elevates the diaphragm and inhibits full lung expansion. We talked about normal blood gas, PO2, POCO2, HCO3. We talked about that. Overinflation. We talked about barrel chest. The person works harder to breathe, but the amount of O2 with barrel chest taken in is not adequate to oxygenate the tissues. Insufficient oxygenation occurs with chronic bronchitis and leads to generalized cyanosis and often the right-sided heart failure known as cor pulmonale. Body depends on the cells in the body, particularly the red blood cells, to carry oxygen so they can carry out their functions within the body. Inadequate arterial oxygenation is manifested by cyanosis and slow capillary refill, less than 3 seconds. A chronic sign is of cyanosis or low oxygenation is clubbing of the fingernails. A late sign is clubbing of the fingers. The key to respiratory status is the assessment of breath sounds. So you want to assess for crackles and wheezes like the breath sounds or high-pitched whistling rather than just categorizing them as rales or rhonchi. This translates better to other clinical professionals. Teach client to sit upright. The tripod position, you'll see them sit on the edge of bed, hands over the bedside table, or if they're in a chair, they can lean forward with the elbows resting on the knees to create that tripod. Teach diaphragmatic and pursed lip breathing. Those prolong the expiratory phase so that they can eliminate more CO2. And it also prevents bronchodilator collapse by creating a little bit of back pressure. Administer O2 1 or 2 liters nasal cannula if it's necessary. As a nursing measure, we're allowed to administer up to 2 liters nasal cannula without a doctor's order. Encourage a patient to pace activities to conserve energy. Take frequent rests. Maintain adequate dietary intake. Promote small, frequent meals rather than big, large ones. So 6 small meals would be better than 3 big ones, as it puts pressure on the diaphragm, makes it harder to breathe. And large meals also will wear the patient out. Very taxing. Increase calories and proteins, but don't overfeed. Encourage them to eat their favorite foods. A lot of these patients will be thin. They're not getting enough calorie intake. Encourage them to eat their favorite things. Things we wouldn't normally want and recommend a patient to eat. These patients may be good to eat that if they need those extra calories. Normally we wouldn't encourage people to eat something like pizza or Twinkies. But in this case, it might not be a terrible idea if that's all we can get them to eat to increase their calorie intake. Obviously, we want to encourage them to eat a healthy diet, but the additional calories are necessary. Dietary supplements for people who continue to smoke. Vitamin C is recommended. Magnesium's a big deal as it works with the calcium to help with the muscle relaxation, such as it relaxes the smooth muscle in the respiratory system. You want to monitor magnesium phosphorus. Encourage them to take adequate fluid intake. For most, they recommend 3 liters a day unless it's contraindicated by something like CHF, where they're retaining fluid. Fluids should be taken in between meals rather than with meals, so that'll prevent that stomach distension, decrease pressure on the diaphragm. Teach prevention of secondary infections. We'll talk just a little bit about that in a minute. Teach about medication regimen, when to take them. Things like anything that's inhaled, sometimes they have side effects, such as with inhaled corticosteroids, they need to rinse their mouth after they administer those, and are aware of the signs and symptoms, such as thrush it might develop. Encourage them to start smoking if they haven't already. Also encourage other health promoting activities such as exercise, things of that nature.